Welcome back. You're still watching Daybreak on this 23rd day of May 2023, and I'm still with the lady and gentleman, Peterson Wachira from Kenya Union of Clinical Officers. He's the chairperson there. We also have Donald Ngalula, who is a nurse, still looking for, I don't know that he's still looking for work, but he'll be telling us about that. We have Dr. Njoki Fernandez and Dr. Bethel Libea. And Daktari, let me ask you this. When you have a nurse qualified at diploma level, another one at certificate level, and another one at diploma level, and you're at the hospital, whatever you're doing, whether you're consulting or you're in the theater, whatever it is, or in the ward, when do you need what?
So that's an interesting question. So I'll speak in my experience as a gynecologist. So the different levels of training affect the different capacities that these people are able to do. And we know that at the degree level, it's true, they do a bit more in-depth into the anatomy, isn't it? The physiology, the pharmacy, and they're able then to do more complex management of patients, but then they also do more administration, isn't it? So they're able also then to look after the facilities better. So you will find that in the clinical setup, they tend to be the more senior then in seniority because of the level of capacity they have to do more than the diploma nurses and things like that. But when these people are not available, then you find that your practice is hampered because you have to do with what you have. And these people could be stretched. They're doing their best, but maybe that's not their training. That's not their capacity. And then now they end up doing things that maybe they were not trained to do or not to the best of their ability and to the best of their capacity. And ultimately, the person who suffers is the patient. So we find that when you do not employ the right people at the right level of training, then you find that those who are on the ground tend to practice beyond their scope. And this is a great concern in the whole of the health sector, because when people practice beyond their scope, they're practicing on who? The patient, isn't it? So then you find that ultimately then the outcomes that we would want for our people are not the best. And it's not that the people are not there. We have them. But for you to employ higher cadres, it means you have to offer them better terms, you have to pay them more, because you want the service to the patient to be better. So it really affects service delivery when you, cut corners because of, mainly because of cost, isn't it? Not because of anything else, yeah.
Okay, interesting. And Wachira, when do you need a clinical officer? And where can you say that a clinical officer is able to manage the patients, even when you don't have a doctor?
Interesting. You see, when I was growing up, the first time I came to know about a clinical officer, I was in class 5. A health practitioner had come to our facility, to our school, to teach us about STIs. I still remember he was teaching about gonorrhea. And I'm saying this to show you the impact and the job description of a clinical officer. At the lowest job description, at the entry level, a clinical officer is supposed to work both at the facility and in the community level. Actually, your job description is that you must implement community health strategy and family health strategy, meaning you actually deliberately go into the community, do school health, go to barazas, go to homes, and try and prevent that disease from happening in the first place. Then as you go up, then in the facility, of course, clinical officers are the people you'll find in any outpatient in this country. And across the facilities in every corner of this nation. And many, over time, have actually called us doctors because we are the clinician who actually treats Kenyans on everyday basis. If you go into any hospital, the clinician you are going to meet there is actually a clinical officer. Of course, as we progress higher, now we specialize. At the level of diploma, you can go into higher diploma. Cataract surgeries, 98% of them in this country are actually performed by clinical officers. We have clinical officers, reproductive health, who are doing cesarean sections. We have dermatologists and so many others. And these are primary health specialists. Of course, now the consultants become the secondary specialists from whom these ones can be able to refer to. Then when you do a degree, of course, now you go in depth and you can be able to get a greater scope than that of a diploma clinical officer in terms of the basic sciences, as I think Daktari has said, and in terms of also management. And that is why we have actually even seen many of clinical officers being able to now rise to the to this administrative post of CECs, chief officers. Even right now we're having even PSs. And at some point we have even had a cabinet secretary who was a clinical officer. So clinical officers, they're actually in every corner of the world.
Right.
Albeit with different names. In Africa, we usually call them clinical officers, clinical associates in Southern Africa. When you go to China, they call them rural doctors. When you go to UK, they call them physician associates. When you go to US, they call them physician assistants. When you go to Asia, they call them medical assistants. And that is why probably many people do not know that we actually exist. But we have a global body. And we are actually in pursuit of that single title that we are going to use across the globe so that it can be realized. Okay. So clinical medicine actually started in Africa when the white man, the white doctor, actually never believed that a black person can become a doctor. And so they started on-job training of nurses, and they call them clinical officers. Over time, because of the shortage, because you cannot bridge the gap across the world, even in developed countries, they still have staff shortages. So they actually borrowed USA, UK, as advanced as they are. They actually borrowed from some countries like Kenya, because we actually with that team when they came to benchmark on clinical officers, and actually they were informed by clinical officers in Kenya for them to be able to start the physician assistants and physician associates.
Okay, but so at the hospital setup, when do you say that now this is beyond me, I have to refer to a doctor?
So we have what we call scope of practice. The scope of practice simply provides for where can I reach, and then I can be able to refer this patient. And basically, there are those conditions that you're able to manage up to a certain extent. And of course, when you're getting some complications, then you're going to refer them to a doctor, depending on your level.
Okay.
The referral will be at different levels. If I am a specialist clinical officer, of course, the general clinical officer will refer to me, and then I'll be able to assess where I can be able to manage. Well, if I cannot be able to manage, then I'm going to refer to a consultant who, of course, will be higher than a specialized clinical officer. So it is the scope that actually guides.
All right.
And I think as a clinical officers, because we are trained on need basis, clinical officers were trained on need basis to be able to address the common conditions.
Okay.
So there is a certain level where we reach, and then now we have to refer them to.
Okay.
Yes.
All right. Donald, you are 33 in your class. Where are your classmates now?
Well, out of our graduating class of 33, nearly have gone abroad. Most of them have gone to UK. Actually, the first batch, among the first batch of the nurses who were taken to UK from the bilateral agreement between Kenya and UK were from we had three. Two from my class and then one from a year ahead. Some are in US and two are in Australia. The other remaining nearly half, we are here around.
When are you leaving?
Well, that's a great question because I get asked that quite often. Other nurses are leaving. The market is open. Why are you struggling with unemployment here? You see, Sam, I'm quite a firm believer that systems can change and that I would love so much to be part of the processes that will see into it that systems have changed to what we want and what works for us. Because people who come up with policies are people like us. They need to be informed by someone. The technical people need to get information from someone. So I want to be part of that process that ensures...
So you're moving into policy?
Yes.
So apart from the opportunities available in the counties or in the public hospitals, would you have wanted to practice as a nurse in the hospital?
Well, at this moment, I don't think so.
Why?
I hung my lab coat 2 years ago, and I don't think I'm ready to go back to it. I'll give you to the experience right away from internship. During our year, we waited for 8 months for us to be posted, and there are others even right now are waiting. We waited for 5 months to be paid. Working in KNH, during COVID time, I was managing around 36 patients, 24, 36 patients. That's a huge burden. So giving these experiences that we are made to go through, that is delayed internships, delayed salaries, poor working environment for nurses and other healthcare workers. This one, it influences our ability to want to practice locally in our own healthcare system. Because why would I offer myself at my young age to work in a public sector that is highly understaffed, people are underpaid, poor working conditions, and being young as I am, I mean, I have my own health to take care of, my own mental health and physical health to take care of. So these problems affect not only me, but many other young nurses. And actually the conversation we are having right now with other young healthcare workers, I was talking to Dr. Libea and other young nurses when we meet, is what we are telling each other, let's get out of the bedside. Because if we cannot be appreciated at the bedside, then let's go where we will be appreciated better. Once we drain this swamp, then the government will feel the pinch that we are losing nurses, we are losing healthcare
The patients will have felt the pinch.
Yes.
Pharmachalia.
But you see, there's only, you can only go as far. At times, you can only go as far. These patients are also our relatives. We feel for them. We will want the best for them. But for people to take action, I think policies have been formed. People have talked so much. What we want is action. So for action to be taken, then we as young healthcare workers have to also take drastic actions. And that if it includes getting out of the bedside and going into other sectors of the economy where we'll be appreciated better, then the better.
How old are you again?
I'm 27.
27.
Yes.
Dr. Libe, how old are you?
I'm 28. I'll be turning 29.
You know, it's very sad, Sammy, that let me take it at that point when we talk about when they say leave the bedside. That means that then where he could have been working in that county and referral hospital, instead of having 5 nurses, then there'll be 4 because he's not there, and the patient burden continues. I just want to broaden the picture a little bit, because we don't realize the impact of poor human resource planning on the health of the people of our country, because that's why we are here. And I think the gentleman from the Clinical Officers Union has mentioned it. When the people of this country cannot, and there are 2 aspects. There's the treatment, yes, and then there's also the prevention of disease, like he's mentioned, and the promotion of good health. And all these are health human resource that is required to treat in the clinics, in the hospitals, in the bedside, but then also prevention of good health in the communities and promotion, And health is not just about the absence of disease. There are other aspects. There's nutrition. We have all these nutritionists who are part of the healthcare workforce. There is aspects of housing. We keep talking about good housing as an aspect of good healthcare. Sanitation, water, all these are aspects of good health. And the tragic thing right now is, I was just commenting that we are expected to deliver an economy of how many trillions? Almost 4 trillion, isn't it? this economy will be delivered by Kenyans. Kenyans are people.
You're talking about the budget?
Yes, I'm talking about the budget. For you to deliver the budget, it's Kenyans who are working, isn't it? So this human machine called a Kenyan will not deliver on that budget if we are not healthy. We will not be able to get down to the ground and work. Because right now, Sami, people are so stressed. In fact, the mental health that he's talking about, because of the way the economy is suffering, people have lost jobs. People are foreclosing on their loans. People are losing their property. People are losing their sources of livelihood. And that mental stress is affecting the way we do our work. Right. Coping mechanisms, people are now getting into substance abuse, drug abuse. There's a lot of domestic violence in their homes. People are fighting with their spouses. And ultimately, the broken Kenyan is not able to deliver on this economy. So which comes first, the chicken or the egg? Do we want a booming economy? Yes. Who is going to deliver that economy? The Kenyans. Are we looking after their health? And how do we do it? A critical aspect is the human resource for health. Like my colleagues have said, we have policy, we've written papers, we've eaten enough mandazi in hotels. We know what needs to be done. Right. Unfortunately, we tend to politicize what is actually very simple. Isn't it? We know the numbers, we know the ratios, we know where we know everything. Why is it that we are not then able to get on with the job? We are politicizing health at the mercy of Kenyans, which is very sad. So we know all these stories. I mean, there's nothing here we are saying that people don't know, have not documented. And government has brilliant minds. They have the best minds. So why is it that they're not able to get on with the story and just do what needs to be done to save the health sector? And when you save the health sector, you directly save the Kenyan economy. That's what I think.
Right. And Dr. Libea, I want to understand from your perspectives, because yes, you said that currently you're not in the space of practicing as a
pharmacist.
Right? So what attempts have you made to practice what you learned in school?
Thank you, Sam. Perhaps maybe to begin with is to share what a pharmacist does. That will give a better perspective of my response to your question. And of course, in Kenya, we have two cadres of practice of pharmacy. There's a pharmacist, and then we have what we call pharmaceutical technologists, who are trained at different level with different scopes of practice. At the diploma level, the pharmaceutical technologists are mainly trained to dispense medicine. So when you walk into any facility, you're likely to find them at the counter dispensing medicines. And then we have the pharmacist, who mainly is trained to be a part of the patient care team or patient management team. And you know, these are teams that take care of the patient. That is made up of the nurses, we have the clinicians, and the pharmacist there to handle anything to do with the drugs.
Right.
So the primary training of a pharmacist is to ensure that there is delivery of pharmaceutical care to the patient, wherever or whenever or whichever place where we have drugs. So having trained as a pharmacist, having been equipped to deliver pharmaceutical care to patients at, I'll say, a hospital facility, that is my primary training, which attempts have I made to deploy the skills I have? Since I left school in 2020, I did my internship. I made an attempt to set up a facility, that's a retail pharmacy. But of course, the back of my mind was to use the facility to deliver pharmaceutical care to those patients that I'll be serving. But shock on me, things were different on ground, as it is said, because the retail pharmacy is mainly driven as a business as opposed to a delivery of pharmaceutical care. So if you are doing things professionally, then you're likely to be driven out of the market soonest. I mean, you can't survive in that market. And so I had to close shops and look for other things to do, because, I mean, at the back of my mind, I was torn in between doing business or delivering pharmaceutical care. And as a professional, I chose delivering pharmaceutical care, which was not able to sustain the business. So I had to close shop and go back to re-strategize. So that is an attempt I made to deploy my skills. From that time when I hung my lab coat, that is April last year, I haven't had any opportunity to practice pharmacy. You know, in the medical space, things evolve really fast. I mean, developments come in, day out. So if you step out of the place of practice for even a few months, when you come back, it will take time for you to catch up because there are new developments each day. So I read from the same script. Going back to clinical practice may be a tall order on me unless I'm willing to make that sacrifice to catch up with the developments that have been happening for the last 12 months. And to buttress the issue of human resource, you know, sometimes when we...
Just move away from that, because I'm just lost, because if you haven't practiced since, I mean, those years that you've mentioned, then we're losing you. I mean, how many years did you spend in school?
I spent 6 years in school with one year of internship. You know, the University of Nairobi with the strikes and all that, so there was one added year. 2017 literally went under the drain, so that added to my years, to 6.
Ordinarily, how much time should you spend there?
5 years, and then plus 1 year internship.
Plus one?
Yes.
How much was the cost of that degree?
I was government-sponsored, so if we are to look at it through the lens of self-sponsored students, they were paying 474,000 a year.
Times 5?
Times 5, yes.
That's more than 2 million.
Yes.
2.3 or 2.4 million, thereabout. So what happens to that investment?
We have to deal with the hard reality. It's a wasted investment as it is currently, because people invested that amount of money. And unfortunately, in my class, we were around 75 of us. And when we were reporting in first year, 49 of us were government-sponsored, and we had around 112 in that first year class. So meaning more than a half were self-sponsored. So along the years, there is that attrition. Yeah, so we ended up graduating 75 of us. Out of 75, only 2 that I know are in county governments, 2 employed by the government. The rest of us, people have found different ways to cope up. So they've gone out of the primary place of practice of a pharmacy. That is the clinical setting. So people have gone to regulatory affairs, other issues. I mean, so that is a wasted investment, literally.
Exactly.
And maybe some...
Just hold on, please note it down. I want us to take a look at the feedback that has come to us via Citizen TV. Kenya Tam Gichuku, the hashtag to use is daybreak on what Kenyans are saying this morning. I mean, interesting stories, but also disturbing in as far as the future of the healthcare. Samuel Oworth, you're saying that having been in a public hospital, the shortage is not artificial. Some have to work for 12 hours to at least cover each other because of the shortage. Someone else? This is Brian Chamwa. Policymakers, healthcare institutions and stakeholders to prioritize the health sector human resource crisis and work together to develop sustainable solutions that ensure an adequate and skilled healthcare workforce to meet the healthcare needs of communities. Samuel Oworth again, it's time to act. Health sector is in a serious human resource crisis. Those who want this government to fail will never talk about the looming crisis. Okay. Does anyone want the government to fail? I don't know who this is. Or maybe it's the same person. Crisis in healthcare sector is intentional. Faceless individuals, busy, strange healthcare sector of cash as part of their strategy, a strangled healthcare sector of cash as part of their strategy to revert it back to the national government. Whoa, okay. Remy Butia, proper management of HR is critical in providing a high quality of healthcare. A refocus of HR management in healthcare is needed to develop new policies. Effective HR strategies are greatly needed to achieve better healthcare outcomes. Honorable Lilian Sioi, the health crisis in Kenya will be solved by having a health service commission that will deal with all human resource issues in the health sector like TSC does for education. Health should never have been devolved. We blundered. I don't know how popular that is on this panel. The only way of ending health sector human resource crisis is by reversing health docket to the national government. Counties have failed miserably because they can't get enough revenue to manage it. All right, Raz Bashir, let health to be taken up by the national government, mainly HR management, for instance, hiring, deployment, transfers, etc., and counties to be left to handle developing infrastructural facilities for health and purchasing of drugs. Governors, no health gets bigger allocation, hence the obsession. I mean, a bit mixed reaction, and we'll be tackling that question about the conversation around taking some of these services back to the national government. But you wanted to add something to what Dr. Libe was saying.
Yeah, and I actually wanted to share some facts regarding human resources, and the reason as to why we are saying that we are not short of policies. In 2013, we had a HRH conference, WHO conference in Brazil. We had a high-level delegation. It was led by our cabinet secretary, then was C.S. Macharia. In that conference, Kenya made certain commitments, 5 of them to be specific. Commitment number 1, and that is where we actually dropped the ball, was that because we were transitioning from the national government to counties, that we are going to have a human resource for health interagency coordinating committee, what we call HRH ICC. This HRH ICC was to be at both levels, in the counties and in the national government, to do coordination for effective management of human resources. Commitment number 2 was that we were going to employ in every year 12,000 health workers to bridge the shortage. It was disaggregated into the cadres and their numbers. Number 3, of course, it was about the community health extension workers, who were to be 40,000, who would pave way and now bring on board the health promoters that we are now seeing. The commitment number 4 was that we were going to look beyond emoluments, beyond salaries, as we budget for health human resources, to make them efficient and effective in delivery of health care. Commitment number 5 was that we were going to also use PPPs, public-private partnerships, to ensure that we capacity build the utilization of HRH, of course, also for efficiency and effective management. So that plan, that lack of coordination, and that is why I'm saying that is where we dropped the ball. If we established the HRH interagency coordinating committee, we would have actually been able to translate these policies. A policy on recruitment and annual recruitment of healthcare workers would have happened since 2013. In 2014, in furtherance to that, the ministry sat, as she's saying, that we have sat and in very nice hotels and made very good documents. We made what we call staffing norms and standards, a document that guides how many health professionals in each particular cadre do we need in what level of facility by which year. By 2018, an example of clinical officers, we were supposed to have 16,278 in public employment. That is from the staffing norms and standards made by the Ministry of Health. In 2018, we only had 5,000 clinical officers. We had a deficit of 11,278. Further to that, the projection by 2025, we actually supposed to have around 30,000 clinical officers in public employment. We only have 7,000. These numbers were disaggregated for every cadre in each county, and they were actually forwarded to the county. But then, either the budget never followed, or the political goodwill, which is actually the culprit here. There was no that political goodwill to ensure that we established structures, to ensure that we have better management, better and effective management of health human resources. And that is the main problem that we are having. That you can see when it comes to teachers, there is a very nice plan on how do we recruit them annually. The same with police, the same with the military. If then in the health as a social science, that is one of the, those are, what do we call them? The ones that make the economy grow, the enablers. Health is one of the enablers for the economy. Why then don't we seem to have, not even to have a deliberate plan? Actually, the plan was there. We don't have the will
to implement it.
To be able to implement. And as long as we actually do not have a plan in action, we will have more of my brother the pharmacist here, my brother the nurse, the 12,000 clinical officers. You can imagine a situation where
5,000 doctors.
5,000 doctors. A child is dying somewhere because they have diarrhea and vomiting.
Yeah.
Yet there is a clinic officer somewhere who is now dying of suicide because they are frustrated. So if you look at the prioritization of the government, and when this government was coming into place, we actually met, and they told us that they have a plan. And one of the plan was to employ 20,000 healthcare workers immediately. They came into place, and of course follow up on the plan on employment of other healthcare workers. And in addition, to constitute a task force, because we realized, as much as we talked about a health service commission, it became an ideology of the employee through their unions, and the governors didn't seem to want that. And we said, okay, our issue is not with the commission. It's not the commission we want. It is that we are having some challenges that need solutions.
Right.
And so we suggested to the president when we met, because we met, and I'm actually the one who gave him the memorandum on behalf of the health sector. We had an agreement that when he comes into place, he was going to constitute a task force where we would have a round table between the counties, the Ministry of Health, and the health workers through their unions, and we would discuss, if it's not the commission, then what can we be able to provide so that it becomes the solution to the many challenges that actually be there for the health sector, so that we can finally guarantee Kenyans of health as we are supposed to actually do under Article 43 of the Constitution. Yes.
And Daktari, so when you listen to these, allow me to call you young voices.
Yeah, they're very young.
That's what you are. When you listen to these young voices that 3 years after graduation, they feel like they may never get the opportunity to practice. He has already ruled that out. He says that if he's to go back, there are certain sacrifices so as to catch up with what has changed. I mean, really, what are we doing? And what must change now?
I like the conversation that you asked about numbers, because I want to bring in an aspect of, we've seen the coups, they've changed the whole aspect of, they've separated training from funding. And you saw, it's been in the news, the kind of money that the medical schools are asking to train doctors, right? Right now we have doctors being churned out every year. They have a certain number of doctors, a certain number of nurses who are already in training. If this is the current crisis we have of unemployment, what happens to the young people who will graduate at the end of 2023, at the end of 2024? What is the plan? Should we stop training healthcare workers and say, until we have absorbed the ones we have, we close the medical schools? Because there is no way you're going to keep churning out these doctors and there is no plan. And then look at the numbers. They're saying that now in the next, from this current intake, medical training will cost 500,000, 400,000, you know, big numbers.
Right.
So people are actually going into debt to take their students to study medicine, to study pharmacy, to study dentistry. And then after all that investment in 5, 6, 7 years, you find that you have not wasted, but yes, the money has gone down the drain, and these people have nothing to show for it. So even as a health sector, you will lose the will of young people to study, because what's the point of studying if you will not be able to be employed? For those of us who are parents in medical school, because some of us have children who are actually studying medicine, we feel it, because we are paying their fees and we are paying the high cost of training. And I'm concerned that at the end of this, our children will not practice medicine the way they did. So like he says, what is the plan? It cannot be an avalanche that is just rolling and it's just gaining momentum. And what is the plan? How many young medical professionals are we going to lose through suicide, through hopelessness? How many young professionals are farming, which is a good thing, but farming should be a side hustle, you should be practicing what you are trained to do. How many young people are doing whatever it is to put food on their table? And yet, the doctor-to-patient ratio currently in the country is 1 in 16,000, as opposed to 1 in 1,000, as what the WHO recommends. So we need the people. We have the gap. Where is the goodwill? What is the plan?
Okay, can I add something?
Please go ahead.
All right, thank you. So thank you so much. Just picking up from where she's left, we all know that the Constitution captures that Kenyans are entitled to the highest attainable standard of healthcare. And she's tied a number to that, what WHO recommends, 1 to 1,000. And sometimes we may think these numbers are just on paper until when you get on ground and you need medical services is when you see the shortage. For instance, if you look at the numbers in Kisumu County, for example, the doctor-to-patient ratio is 1 to 6,500. If we look at the deficit that we have is around 900 plus doctors that Kisumu County needs to employ to bridge that gap. If you look at Kisii is 1 to 6,000. So the deficit is around 600. And this is replicated across the country in different counties, different numbers are needed. It's not that we don't have professionals. For instance, my registration number as a pharmacist is around 4,000. And factoring in attrition, deaths and all that, meaning we have less than 2,000 pharmacists in the country. And how many pharmacists do we need in this country? Looking at medical doctors, currently I think the registration is around 15,000 or thereabout. And we need far much more than that. So we have around 4,000 unemployed doctors, and yet there is a deficit in the public system, public healthcare sector. So a call needs to be made. And it's not that the solutions are not there. As they have mentioned, policies are there, we've discussed this and all that. If the government was able to second Cuban doctors to work in counties, why is it so hard to absorb the 4,000 and second them if the counties are not able to employ? Right. At the end of the day, it's not about the county or the national government. At the end of the day, it's about Kenyans, serving Kenyans, ensuring that they have, their healthcare is well taken care of. It's not about counties or national government. And just to add to that, if things remain as it is, people are thinking of shipping out of the country. So what happens to those that will be leaving behind? Who will be handling them? That is a bigger picture that we need to look at, as opposed to looking at the healthcare as an expense. Who will be investing in the healthcare of the nation? Because you need a healthy people to build the economy. Right. So that is a bigger picture that we need to have at the end of it. It's not about employment and underemployment, but the healthcare of the public. Who will take care of them? If this lot that is underemployed, that feel unappreciated, ship out of the country. And maybe just to bring to the attention of the nation as well, and maybe you as well, perhaps you might not be knowing, the public healthcare system rests on the shoulders of medical interns. And at the moment, we have interns who are posted in January. They've gone 5 months without salary. Some of them have gone on go-slow. The last 2 weeks, they're not going to work because you can't work 6 days in a week, 12 hours a day, and you don't have food to put on the table. Remember, these are people who have just come out of the university. They are fresh from the university. They don't have any savings. The only loan that was advanced to them was by the SACCO, and it's 50,000 shillings just to get them started. But they haven't been paid 5 months down the line. Food is not there. Rent is not there. You're expected to show up and serve the patients. It can't happen. And so they've gone on go-slow. And I don't know what is happening because promises were given by the cabinet secretary, but they haven't been fulfilled. We have another lot, around 400. They graduated or they finished school last year, sometime last year, around August. They haven't been posted up until now. And as I mentioned before, the practice of medicine, you need to be present for you to catch up with the development. So if you have a gap of 7 months, 6 months, there's some things you'll forget. Right. And by the time you're posted, even the training won't be able to meet the objectives that it needs to meet. So there's a call out there that the government needs to do what it needs to do to be able to bridge the gap that is there in the healthcare sector.
How much is the salary of a medical intern?
A medical intern, we don't call it salary, but we call it an upkeep allowance. So they're given a basic salary of 41,000, and then there are other allowances that come in between, depending on where you're posted. Yes.
Interesting. So, Ngalula, how are your colleagues, those that moved out of the country, how are they faring? What are their experiences?
Speaking to those ones that we still keep touch with, they are faring on well. The opportunities to advance your career outside is open and better than what we see here. For nurses who work on the clinical side, the bedside in Kenya, your progress is much slower than people who work outside the bedside. But when you go abroad, talent is appreciated and skills are appreciated. So long, if you show interest in pediatrics, the hospital, in fact, the hospital itself sponsors you to do what? To further your studies. If you show interest in whatever field that you want, your hospital will sponsor you and re-employ you back into that specific, to employ a specific skill set.
Right.
So they are doing well. For those ones who are in UK, most of them are planning to shift again and go to the US, because US.
Sport for choice.
Yes, because for US, planning to move from Kenya to US, it's quite takes quite a longer time. It's a little hectic than Kenya to UK. So most of the guys who are in UK use that one as a platform to ship out to the US as their ultimate destination.
Daktari, so I've had some governors complain that, yes, they have hired doctors, but half of them have gone to further their studies. Maybe they are studying in Nairobi and they're attending certain hospitals. So they're feeling, why should I continue paying my doctor who is away, not attending to the population? Tell me about that, but also what it takes to make a specialist.
So in my time, like I said, it was under the central government. After you finish your internship, you work for a certain period of time and you apply to the Ministry of Health, and they would sponsor your postgraduate training, after which then you are bounded. You had to go back to your station or wherever they will post you to then practice your speciality. And you cannot run away from specialized training, because we need specialists in this country in all the various aspects. And it's not a waste, it's an investment that you're making. And I think I've seen the pull and push between the governors and central government. They're saying that we are infringing on their rights in the constitution to manage healthcare, which is a devolved function. But we're thinking, you know what, at the end of the day, I like what the president is doing. He's stepping in, because we all belong to national government, yeah? The whole devolution thing and the governors is a dispensation. But ultimately, the health of the people belongs to the government. And you need to do whatever it takes to make it function. So I like the Kenya Human Resource Advisory Committee that was created, and fantastic people have been put in the advisory role. Can then that be the platform for advising on human resource in the countries? I'd like to ask the governors to just get together and agree that we need to move this, because it is a devolved function.
Right.
But can we prioritize healthcare? Because right now it works depending on what the governor feels. If to them it's a good thing, they push it. If it's not, then they give other priorities in healthcare. And that is why we still feel that human resource for health should be a national function, so that then it is funded by national government, regardless of what the challenges the counties might be having. And even sponsorship, payment for postgraduate, all these things, I feel, should be done at the national level, so that then the governors can deal with equipping their facilities, buying drugs, those are the functions.
But what do you think about, because a practical challenge, you've hired doctors, but they're not available because they're furthering their studies. How would you deal with that, even if you had to manage it from the national level, so that you don't have shortage and the patients in that county suffering the disadvantage?
You see, if there is a plan, and at least in those days I used to see a plan, that every year we're going to train, and it used to be per cadre. We're going to train, as a government, 50 gynecologists, 20 radiologists, 10 anesthetists, like that, yeah? So because you have a plan, when you know that so-and-so is going for training, you have replaced them. I mean, there was a plan to replace and to cover, so that then the systems are running on the ground while you release this doctor to go for training. So that's the master plan that we are missing. It was very deliberate. Every year they knew how many they were sponsoring. There was budget for that. There was budget for those people who will replace them in their workstations as they're going to study. And there was a budget for them to be promoted when they came back, because you're coming back now as a consultant. There were plans, and these plans worked. So what happened to the plan? And I think this is where now we are suffering, because we're not executing what we already know. And I really would encourage the president to keep keep his foot on the pedal, you know, keep insisting, because ultimately the health of Kenyans, the buck stops with him. Do whatever it takes to bring back order into the human resource space in healthcare. Yeah, do whatever it takes, because we need to get order in this system.
Washira, tell me, what does it take for a clinical officer to get to the point of specialization, and what cost would that be to the facility they're working at?
For specialization for clinical officers, it actually follows the same route. Doctors and I think all the other healthcare workers. Though I think for clinical officers, actually there has been less support. It's one of the things that we have actually been fighting for. So to add to that conversation, I think the biggest problem with the county is that they feel that they continue paying somebody as they work elsewhere. Because actually in specialization, you are working. There is a collegiate way of specialization that has been adopted by most of the universities now, where you can actually work in a facility, probably in even your county, if they have the facilities needed, and you'll be able to be probably mentored by consultants from where you are, which is one of the ways that I think is solving that issue of we are paying you, but you are working elsewhere. But also, the training function lies with the Ministry of Health, not the counties. So what I think should be the solution is that when these people, because the planning for training usually happens at the Ministry of Health, why can't the ministry then, if you're moving out of your county, take up even your emolument for that time? And then when you go back, then probably the county can either take it back, or you may not actually have to go back there, because sometimes you find that one county would be having more specialists than the other, and probably the need would be more in another county. So if they can be able to take up the whole cost, probably that would be the solution. The second one is what I've said, the collegiate way of training. Instead of moving from Nyeri County to come to Kenyatta National Hospital, we can actually have our officers being trained at Nyeri PGH and offering their services there. If the facilities that are available can actually be able to accommodate that. So usually the cost is borne by the Ministry of Health, but for most of them actually, because they are limited resources, they actually have to pay for themselves, and that cost will depend on whether it is a higher national diploma, which is a bit cheaper, but of course if you are going for a master's, that will be a bit expensive.
Okay, interesting. Dr. Let me get this from you, and I ask this because I mean you've been in the practice for quite a couple of years. So we still suffer or face challenges with financing of healthcare. That's why even the government has been working on universal health coverage since President Uhuru Kenyatta's second term in 2017-2018. Then currently the conversation is about empowering the National Health Insurance Fund, that is NHIF, or is it NSHIF as it was proposed? Are we getting somewhere? And what is this that we need to do? Because much of the resources, I think, out of the wage bill, close to, is it 40% or thereabout, goes to health sector. So there are substantive resources going to the sector, but still not enough. What is this that we need to do to ensure that even this aspiration for universal health coverage succeeds, and having in mind the NHIF and all the conversations around it?
There's a conversation I've been listening to in some quarters, which I find very interesting, that one of the ways in which I feel, and it's a good idea, that the health facilities become self-sustaining, so that that health facility is able to generate enough money, because they're offering a service that people are paying for, that they're able to generate enough money to meet their costs and their expenses, including paying for their human resource, their labs, their pharmacies, their everything that that facility requires, a bit of autonomy.
Right.
And that should be able to happen, isn't it? Because each of these health facilities are run as independent units, so that then they don't have to keep asking the county government or national government for support. That requires really a lot of governance and a lot of goodwill, because these facilities are all revenue generating. They're all streams of income. But why is it that then they're not able to manage their affairs and become autonomous units of generating revenue? NHIF, again, there needs to be a plan. And there needs to be goodwill to make NHIF succeed at a national level. And if that plan and that goodwill is not there, no matter how many times we change the management, we change the board, we change the CEOs, they will still fail. Because the infrastructure that is supporting the management of NHIF and the thinking and the logic, which is very good, if that is not in place, you know, it will just be musical chairs. And the same thing even with us, with organizations like KEMSA, you know, we will change the board today, we will put in another board, but we will put in a new CEO. But if the underlying thinking and the logic does not change, these institutions will not succeed. And unfortunately, these are the institutions that Kenyans are looking up to manage the healthcare. If NHIF does not work today, the majority of the country, our citizens, will suffer, because most people don't have private insurance, unfortunately. Most of us are relying on NHIF. The amount of money that NHIF collects per month from premiums, I mean, from contributions, where is that money going? Is it being used efficiently? Can that collection be increased? And NHIF should stop becoming a political agenda, because that's another thing. We politicize it, we lose it completely. Yeah. Right. So are we managing our resources properly? Are we paying for the right bills? Is there fraud? Is there wastage? Is there abuse? Is there misuse? And how can we then make it better for the common mananchi in other countries? And I keep saying, I don't see why we can't do this. Funding NHIF, if you're going to wait for me to volunteer to pay my 500 shillings, it's not going to work, isn't it? And that's what we're waiting for, Kenyans to volunteer to pay to NHIF. I'm not going to do it. I'll only pay when I'm sick, which is a problem. Yeah. In other countries, they use part of their money for like, for example, we're all using power here today. So I have contributed by using electricity, isn't it? We are all online, we're all using data. So we are all using fuel, and a small portion of this can then be channeled to health, to NHIF, isn't it? So that then you're able to pay bills. That's a lady who sells vegetables in the village might not contribute 500 shillings to NHIF, but she's using a matatu, she's using airtime, so she's indirectly paying for it. Are we able to take a shilling or two from her expense and take it to NHIF? Then you will have enough money. But then the question then is, with all these billions that NHIF will collect, are they going to use it properly, or does it become then another pot of cash for us to do what we are known for in this country? You know, it can't be. So what is the plan?
Something on funding.
Just hold it so that I take a look at feedback, then I can come back for the closing remarks on what you're saying. Citizen TV Kenya at Sam Gituku, the hashtag uses daybreak, and Zach, you're saying that this is not the only sector facing the same crisis. All modernity institutions are not working in Africa. Professionalism is becoming unethical due to frustration. The national state must take stock of all professional space for planning. National state, oh, that's new. Kahi Job, you're saying that I'm at my nursing internship practice currently, and I'm already afraid of the job market. Counties have failed miserably. Health sector should be reverted to the national government. Sir Nixon, we're in a very sorry state, that of the government gambling with the health of citizens. For instance, look at the neglect of poor equipping of dispensaries, which act as first aid in the village. Sad. Rev Hari, the only remedy to this perennial problem in health sector forever is to have Health Service Commission, whereby all the issues affecting doctors, nurses, clinical officers, promotion, their salaries will be catered for. That should be done as soon as yesterday. God bless. And one Kio Nyainda, you're saying, given the interlinked and multi-sectoral nature of HRH, you mean human resources in the health sector, issues, more comprehensive interventions that incorporate better human resource management, governance, policy, training, and funding would be ideal. So, I mean, we have said a lot this morning, but what is it that we must take away with ourselves, starting with you, Galula?
Thank you very much. And so, what my closing remarks will be this, and this one goes to the governors, that they have a headache of managing human resource for health. This headache wants people are proposing that this headache be taken away from them so that they breathe. So they should allow themselves to be relieved of this headache. Thankfully, we now have the KHRAC, the Health Amendment Bill 2020, gave it more functions and power to do what we healthcare workers want a health service commission to actually do. So if this advisory council can be operationalized and given more flesh and more teeth so that they carry out more tasks than just advisory, and then all healthcare workers be centrally managed, either by whatever, whether it's a council or an advisory or a commission, so long as healthcare workers are managed centrally and the headache is taken away from the governors, then I think we'll be making positive steps.
Would that make you go back to the bedside?
Possibly. Possibly.
Okay, Wachira.
Yeah, thank you, Sam. I think what I would say as a way forward is that we must very objectively look at the challenges that bedevil the health sector. And the root cause of that being the financing gap, as she has said. Right now, clinical officers have been out for 1 year. Those awaiting internship, they have not been posted. We have been fighting for their posting. When they are posted and they are going to finish, they are going to get into a job market that is not ready to absorb them. When they are absorbed, they are going to be absorbed into exploitative contracts, usually paying half, like we are having with the universal health coverage contracts, half pay, without a pension, without the opportunity to be able and go and further your studies and skills. And the net effect of that, because they are trying to cascade that and have it across the board in the public sector, is that in 20 to 30 years, the gynecologist you are seeing here, you'll actually have to travel to Uganda to get one. Because if you are giving a 3-year contract, and a gynecologist needs how many years? 4?
5.
5 years. A clinical officer in reproductive health, they will need 2 years. If it's diploma, if it's degree, they will need 3 years. So there is no way you are going to get these specialists. And that underscores the need for financing, because it is the financing that is making the Ministry of Health say that we do not have money to post your interns for internship. It is the lack of funds that is making counties come with these innovative approaches to hiring of healthcare workers on contracts. So it's only through better funding, as Kenya committed in 2013 and signed by the CS on behalf of the government, that will enable us to have the requisite numbers of health workforce. And once we have a requisite number, that is the only time we are going to implement universal health coverage, because universal health coverage, if we are going to implement that using primary health care, then the burden is on employment of health resources to ensure we have promotion, prevention, and curative services running.
Great. Now, you'll be the final word, but for you, as you wind up, talk to me just slightly about locum arrangement, especially at the private facilities, and what that means for the sector.
Okay, so locum arrangements are a way in which private facilities survive, because they don't want to hire this person full-time, but they need the service. And I think locum arrangements have become very exploitative, and they target those young people who do not have work, and you need to pay bills. So they are paid, they are so grossly underpaid. And remember, a locum agreement does not have any other benefits. There is no insurance, there is no leave, there is no, so, and many locums, in fact, people work and they're not paid for long. So the private sector also tends to exploit the young doctors.
So they get you when they need you?
They get you when they need you, and they get you on their terms. because that's an area that is not very well regulated. And so it's a pity. But that's how many doctors are surviving. If you look at the kind of money people are being paid, but you have to go and really work those 12-hour, 24-hour shifts so that at least you can put some food on the table. It's really sad. It's really, really sad. And that is where we are thinking, do we want then our children to train in this sector if this is what, it's an area that a sector that is not regulated.
Okay.
And as I finish, my call is to two people. One is to His Excellency the President. I think, please do whatever it is that you need to do. Just do whatever you need to do to figure out HRH in this country. Things are thick, things are bad, and your people are suffering. And the next call is to the chair of the COG, Madam Anwai Guru again. Please, bring your governors together. Let's have a conversation. Let's stop the politics, and let's get the healthcare going in the counties.
Okay. So, Dr. Libea, you had something to add, but as you close, also tell me all this situation and how much it has affected you, that now you're, what is that you're doing? Digital marketing?
Yes.
So how does that even affect you in terms of planning your life into the future?
Thank you. I'll begin with that. I think looking into the future and what has been happening, of course, we're able to pinpoint the source of the problems we're encountering currently. And it has to take political goodwill for it to be solved. So looking into the future, I don't plan my future really in light of pharmacy practice at the clinical level. So I've been left to explore other ways. And one of the areas that I'm looking to get into is in the space of management consultancy. And also what I'm doing currently, the advocacy and policy development. Those are areas that I'm interested in and going forward. As a closing remark, what I will propose as a solution, funding is key in healthcare. If we look at the Abuja Declaration, it states that 15% of the annual budget should be allocated to healthcare. Currently, as a nation, we are at 4%. And that is around 120 billion. If we look at Teacher Service Commission, in the annual budget, they have an allocation of close to 550 billion. So if you are to translate the 15% Abuja Declaration in the current budget of 3.6 trillion, we should be somewhere close to 500 billion. I mean, that will take us steps ahead as far as solving the issues that we're encountering currently. I'll give an example of the 4,000 unemployed doctors. If the government is to absorb them at the entry-level job group M, they're likely to spend close to 12 billion annually to cater for their compensation. So will that be too much to ask?
How many doctors are you talking about with that?
4,000
okay.
unemployed doctors. Well, will that be too much to ask to allocate 12 billion annually to absorb these 4,000 doctors? Because you've seen dams that have been allocated 30 billion, 50 billion. So where is the political goodwill in all this? So my call out there to the president is let us have an honest conversation with the county government, with the healthcare stakeholders on the way forward. Otherwise, it's a ticking time bomb.
You know, I asked you a question, but you decided to narrow it.
Maybe some.
Just hold on. I asked about managing your life. I mean, your life is not just about career.
Oh, all right, yeah, I get you. Yeah, sure. You know, there are many things that are tagged on career and finances. And of course, I would want to settle down in family. I would want to advance my studies. I would want to help my siblings and all that, and those people are close to me because I'm a firstborn. And you know, being a firstborn in an African family, almost everything is tagged on you. There's that what we call black tax. And so people look up to you for help. And you know, when you get yourself to that place where you're not able to help them sufficiently, in a way, it may take a toll on you. So I'm managing with whatever thing I have currently, helping those that I'm able to help. There's some plans are put pending, subject to greener pastures. Of course, when the greener pastures come or things look better, I'll be able to advance them. I won't mention them. All right.
Ngalula, the same question.
Well, great question. I'm a second born in a family of 5. So at the moment, I'm supporting my siblings through high school. And just like Dr. Libe, I also want to settle sometime in future.
Right.
It's not something I'm giving it a lot of thought as at now, because I still want to advance in my career. I've been admitted to do MSc Global Health at the Cambridge Graduate School. I'm not sure how I'll raise school fees though, but the good thing, like we always say, just get started and then probably things will get a way ahead.
All right, time is on your side. Now, Wachira, I'm out of time. I can only afford 30 seconds.
Yeah, that's enough. What I wanted to say is that as employees, as the unions and associations, we actually came out to provide a solution. In March last year, we convened what I'm calling a roundtable, a convention. We brought in Council of Governors, Ministry of Health, and all the players in the health sector. We had an agreement that for us to get into the root cause and get solutions, we needed a joint national task force. We wrote to the president, and the president mandated the cabinet secretary for health to constitute that task force. That has not happened. And my plea to the CS, because it has now taken months after we were actually informed from the office of the president that it had been taken to the cabinet secretary for health, is for her to constitute that task force so that we can actually be able to provide recommendations that will be able to take health sector forward in this country.
Okay. Yes. All right. Peterson Wachira, Chairperson, Kenya Union of Clinical Officers, Donald Galula, a nurse, and Dr. Bethel Libea, a pharmacist, as well as Dr. Njoki Fernandez. Thank you all for making time for us. And did you just say that it takes 5 years post-training after the first degree to become a specialist as a gynae?
So you do your 6 years medicine, 1 year internship, work for 3-4 years, go back and do 4 years postgraduate, 2 years specialist supervision, then you become a specialist. How many years are those? That's a long time. A long time. And all these specialists are leaving the country in droves because we are in demand in other parts of the world. So all that training...
Are you still practicing yourself?
No, I don't practice.
Ooh, after all that training, imagine that. All right, thank you so much for making time for us. And of course, health is not just the only sector that is facing challenges. We strive to speak to as many as possible to understand, especially the young people, what they're going through. Because in this country, we're talking about ensuring that everyone gets an education. Yes, get educated. And then what? We have to keep asking that question. My name is Sam Gituku. Bye for now.